Hi, I'm Clara Keegan. I'm a family doctor in South Burlington, not very far from here at all, and I'm an assistant professor at the University of Vermont. I do a lot of women's health in my practice. I have a full spectrum family medicine, outpatient primary care practice. I practice maternity care, and I do hospital medicine for our inpatients as well. So I do everything birth to death. And HPV has become one of my areas of interest because one of the procedures I do in the office is colposcopy, which is the procedure we do to follow up on an abnormal Pap test. And I know this was listed as the provider track, so I'm curious who here is a provider of medical care and who here does not consider themselves a medical clinician? Okay, great. So there is some data, but I hope that it's set up in a way that it's easy to understand, and I'll keep in mind that not everyone here is a clinician as we go through it. I don't think they specifically asked me to do this, but because I'm just used to being faculty, I will always tell you I have no financial arrangements or conflicts of interest to disclose. I don't think I have any off-label use of medications, and everything here is based on clinical evidence. These are the items that we're going to go through today. What HPV is, a little bit of virology, why it makes a difference. I talk a bit about cervical cancer just because that's how I learned more about HPV, and I think that we have a very robust body of evidence about HPV as it relates to cervical cancer, and then from there we relate it to other cancers that HPV causes. So we'll start with the cervical cancer part, and then we'll talk a little bit about other cancers. And I really do want to focus on vaccination, and in particular what we can do as providers to try to maximize vaccination. HPV is a small virus. It's a DNA virus. Some have RNA. This one happens to be DNA. It only infects humans, and it infects epithelial cells, which are the cells of the skin, the mouth, the genital tract. It doesn't infect internal organs. But once it incorporates itself into the nucleus of the cells, it has the potential to cause those cells to grow more. And so that can either be benign, like a wart, or it can be malignant, like a cancerous tumor. It's a really huge family of viruses. There's over 100 HPV types, and about 40 or more affect the anogenital tract. There are some that are really almost irrelevant, and certainly irrelevant to cancer. Type 1 tends to cause plantar warts. Types 2 and 4 cause the sort of common warts that you might get on your finger, or flat warts, or type 3 and 10. So they do create slightly different sorts of warts, but those are benign. The low-risk anogenital types are the types that tend to affect the genital tract but don't cause cancer, and type 6 and 11 are probably the most important of this group because they cause the most genital warts. The high-risk types are the kinds that can cause cancer to develop, and I've got a few different colors listed here. So type 16 and 18, 16 causes the vast majority of cervical cancer, and I believe other cancers as well. 18 is the second most common one identified in cervical cancer, and it actually causes kind of a different cervical cancer that tends to present at a younger age and is much more aggressive. So screening is less effective for HPV 18 cervical cancer. And those are the two that are in the Cervical vaccine. That only contains vaccines to 2 virus strains, and that's 16 and 18. Then 6 and 11, the genital wart ones, are added in the Gardasil vaccine, which is the quadrivalent. It covers 4 virus types. And you may know that there's a newer one, the HPV 9, which covers 9 strains. So to those original 4, it adds these other 4 that I highlighted in green of the high-risk types. HPV is pretty much everywhere. I have patients who have HPV detected on a Pap test, and they come to me very concerned. How did I get this sexually transmitted infection? And they're really freaked out by it. But the truth is that it's about as easy to get as the common cold. If you look at one time, about 79 million Americans have HPV, high-risk HPV at any time. There's 14 million new cases per year. If you look at all types of HPV, including low risk, 42% of women and 61% of men have some HPV right now. And if you look at high-risk types, it's about a quarter. So it's really, really common. Most of the time, it doesn't have any symptoms whatsoever. And one interesting thing about these anogenital types is that intercourse is not actually necessary. So genital warts, for example, can be transmitted by intimate touching. And we all know that intercourse isn't necessary to transmit plantar warts, for example. So it's just something that transmits by contact. Excuse me. So if we think about HPV as a sexually transmitted disease, it's important to know that you can also find HPV in people who have never had penile vaginal intercourse. But after people do start having intercourse, the prevalence of HPV or the incidence rapidly increases after that. Vertical transmission can occur, so there is evidence that it can be passed from a mother to a child during birth. But most babies who get HPV that way have cleared the infection by the time they're a year old. If we test babies for HPV, they have found in up to 17% of infants whose mothers did not have HPV, they have had HPV at some time before they're 2. So you can get this even at that very young age. In some studies, they found HPV present in up to half of women who had not had insertive intercourse. But of those, about 70% had had some sort of sexual intimacy that wasn't actually intercourse. But then if you do think about intercourse, which is the easiest way to get HPV, it's important to keep in mind that about half of high school students have had vaginal penile intercourse. That's a third of 9th graders and 2/3 of 12th graders if you look at the entire United States. And 24% of high school seniors have had 4 or more partners. So kids who are adolescents are having sex. And if you compare the types of HPV that they have, it's about half within the couple will have the same strain. So some of them have one, in the other one partner has one strain and the other has the other. So it doesn't perfectly match. They're not necessarily getting it from each other. So the point of this all is that it's incredibly easy to get. You can get it without having sex, and a lot of kids are having sex. This is a study of college students. It's actually 2 different studies. The fat line in the middle, let's see if my arrow comes. This fat line is women, and the thin line is men. And they enrolled them in the study having never had intercourse. And then they said, oh, hey, I'm here, I had sex now. And then they started watching to see how long it took before they got HPV. And you can see here where these lines happened to cross. At about a year, a third of these college students had acquired HPV in a year after having sex. So you pick it up pretty quickly, and then just the longer it's been, then you eventually sort of plateau out around 50 or 60% of people. The really cool thing is that while it's really easy for adolescents to get HPV, they have very active immune systems, and they often will clear it. About half, 40 to 70%, will clear within a year. And if you watch women, 70 to 100% clear in 2 to 5 years. So the longer you give it, the more they get rid of it. And men clear 75% in 1 year. So this is why we've really changed our cervical cancer screening. We used to say, you're here for your birth control prescription. I don't care that you're 14, you have to have a Pap test. We now don't even start doing Pap tests until women are 21, because we know so many of those teenagers are going to clear their HPV infection. And for this particular talk, I took out a lot of the stuff I took out the cervical cancer screening part, but if you have questions about that, please feel free to grab me later. I don't know why that did that. Okay. This was a really great review article that was in the New England Journal about HPV and how it relates to cervical cancer. The green line here is sort of saying that same thing again. The green line is HPV infection. So they started around age 12. Huge prevalence of HPV in people who are 20. And then it really just clears away. And by the time people are 70, it's much less common. But these ones that persist, the people who don't clear their HPV infection, are the ones who are more at risk at cancer. HSIL is high-grade squamous intraepithelial lesion. That's the high-grade problem that we can find on a Pap, which is abnormal, but it's not cancer. And that peaks a little bit later because it takes some time for the HPV to cause those changes. And if you look at this orange line, which is cancer, excuse me, you can see that most people who have HPV don't get cancer, and it takes a really long time for that to develop. So compared to the peak of HPV at 20, it takes a couple decades for the cancer to develop. So we have some time, and that's why cervical cancer screening works the way it does. It's also why we don't really have data exactly on how the HPV vaccine is going to affect cancer rates, because we haven't had the vaccine for that long. We've only had it for 9 or 10 years, so we don't have enough time to see it affect cancer yet, but that will come. Next step is about HPV and cervical cancer more specifically. And the reason that HPV causes cervical cancer, I think it's very similar to other parts of the body, but I just know best about the cervix. In the cervix, there's something called the transformation zone, which is where the columnar cells, one type of cell that's on the inside of the cervix, starts to migrate out to the outside of the cervix toward the vagina. And that occurs with puberty. On the outside of the cervix are squamous cells. And In that area, once those columnar cells get exposed to the different pH of the vagina and to the other hormone effects of the vagina, they start to change into squamous cells. And because they're actively changing, they're changing from one type of cell to another type of cell, they're particularly susceptible to the effects of HPV, where it can cause cell growth. So first, HPV causes what we call dysplasia, which is abnormal cell growth that isn't cancer. And then over decades, that active abnormal cell growth can change into cancer, which is a malignancy which could invade. But first it becomes a low-grade infection, which is essentially the effect of HPV just being there as a low-grade cervical lesion. It takes about 5 to 10 years for that to progress to a higher grade lesion. It doesn't occur in everybody. Some people have a low grade that just persists and persists and persists. But in 8 to 28% of people, it will progress to a high grade lesion. If nothing is done, then in about 3 to 5% of those people, it can progress to cancer, but that takes decades. If we look at cervical cancer for HPV, we find it in every single cervical cancer. So there's a very clear link between HPV and cervical cancer. This is a little cartoon that I drew. Here's the little columnar cells on the inside of the cervix, and this straight line is the squamous cells. So with puberty, those columnar cells migrate out to the outside, and then here, where they're exposed to the vagina, it's a more acidic environment in the vagina. There can be infection or inflammation, and there's a different ratio of sex hormones there. So they change, and these cells that are changing are the ones that are affected by HPV. So if we look at it under the colposcope, these cells look sort of like squamous cells and sort of like columnar cells, and that's the transformation zone. Here is a pie chart of the different strains of HPV that are found in cervical cancer. This huge chunk is HPV 16, so that is by far the one that causes the most cervical cancer. Here's HPV 18 causing another big chunk. So the Gardasil, the quadrivalent HPV vaccine, covers not quite 3/4 of the risk of cervical cancer. And then by expanding to the nonavalent vaccine, the HPV 9, we're adding these additional 5 strains. So we're covering about 90% of the HPV strains that cause cervical cancer. As I said, I don't know quite as much about the other cancers, but HPV has the same effect in other parts of the body. And 27,000 people each year are diagnosed with an HPV-related cancer. So that affects both men and women. This chart describes the different locations, excuse me. So in men, oropharyngeal cancer is the most common. In women, it's cervical and vulvar. But HPV also causes cancer of the anus, the penis, the vagina. This is the same thing in pie chart form. The CDC has some really great materials for providers about the HPV vaccine, so I took a lot of their slides and incorporated them in here. Dr. Silverman is one of our otolaryngologists who does a lot of the throat cancer work. This is a patient of his with a tonsillar cancer. So you can see a few things from this picture. One is that this is a man with a mustache. Another is looking at his teeth. I suspect he's a smoker. And this tonsil is so large that it's pushing his uvula to the right. So this is a tonsillar cancer. Oropharyngeal cancer is kind of interesting. What we were taught when I was a medical student 10, 15 years ago is that oropharyngeal cancer is a cancer of men who smoke and drink, and it presents in their 50s to 60s. HPV-related oropharyngeal cancer is actually different. It doesn't differentiate as much between men and women. People with HPV-related oropharyngeal cancer are less likely to be smokers and drinkers. They're younger, and they have more aggressive cancer. So I'm not sure if Damon knows that this was an HPV-related oropharyngeal cancer or not, but this person looks like a male smoker, but he also looks like he might be kind of young, so not sure. But the original kind that we all learned about, the smoking, drinking, middle-aged man, is not going to be affected by the HPV vaccine. But there is a good amount of oropharyngeal cancer that is HPV related, and that actually is on the rise. There is more and more of that kind of cancer available. This is a condition called recurrent respiratory papillomatosis. This is not cancer, this is benign, but this is a condition that is found, fortunately it's very uncommon, but this is a condition of children. And Dr. Silverman has several patients with this in his practice. They acquired HPV through vertical transmission from the mother, and they developed these little papillomas in the oropharyngeal tract, so in the mouth, or the larynx, this is the trachea. And they don't metastasize, they don't invade, but they can become locally so big that they can interfere with breathing. So Dr. Silverman has to see these kids twice a year for a laryngoscopy and to look inside, and he'll actually have to physically scrape away the papillomas. So it's a lot of cost to the healthcare center to treat this. This is not something that's preventable or reversible once it occurs, and the only way to prevent this from occurring is to vaccinate women so they don't have HPV. This is, Dr. Goldman tells me that this is a skin-related cancer. So we think of those skin warts, the flat warts, as not being high risk of producing cancer, but this is a patient who had a finger cancer, a squamous cell cancer affecting his nail bed, which Dr. Goldman tells me was an HPV-related cancer. And then here's another, this is a penile squamous cell carcinoma. So you can imagine the treatment of this could potentially be pretty devastating. Once it's there, and we can't do anything except surgically excise. So the best management is to prevent with the vaccine, which is what we're about to talk about now. So it's 9:20. Great. I rushed through that. Okay. So the HPV vaccine is what is going to hopefully make all that first 15 minutes become less and less of something that we have to manage. Vaccination works. We have evidence that the effect persists. As I said, I think we're now 9 to 10 years out from when this vaccine was originally produced, and we can see that people who got it early on still have immunity to HPV. We have good data starting in 2006 that vaccination is safe. When people do have adverse effects, they're mild, and they don't cluster together, meaning it doesn't look like it was related to that vaccine specifically. It wasn't related to a batch of vaccine here that people got a lot of adverse effects from that particular batch. We also have really good data that early vaccination is more effective than waiting. So that is how I really present my counseling to families when I'm talking about this vaccine. In Australia and the UK, they have been incredibly good at getting vaccination into the population. So in Australia, where 70% of girls were vaccinated, they were able to find that genital warts decreased 85% in girls and 71% in boys, and that's by vaccinating girls. Originally, when the HPV vaccine was released, it was only recommended for young women. And they found in Australia that by vaccinating young women, they were protecting boys as well. In the US, where a third of girls were vaccinated, a much lower percentage, they still could see reduced prevalence of HPV infection from 11.5% to 5%. So vaccination cut just the presence of HPV in half. They also were able to see that the rate of diagnosis of a high-grade cervical problem decreased quite a bit. And in the military, where they're really good at getting everyone vaccinated, they could see a reduction in warts. We're able to track it by warts first because that's something that develops quickly. As I keep emphasizing, a lot of this takes time, so we don't have full data about the full effect of what this vaccine is going to do yet. Vaccination works really well, and I have here a few different ways to look at that. This, again, is the prevalence of warts, and each line is a different age group. So here, this is from 2003 to 2010. This red line is the 15 to 19-year-olds. So these are the ones who are vaccinated, and you can see the red line, the prevalence of the warts goes down in the age group where vaccination was offered. Everyone else, it was going up. This is just testing for HPV. The first column is any HPV at all. The second column is HPV that's not involved in the Gardasil vaccine, and then the third line is the HPV strains that are in the Gardasil vaccine. This 25 to 29-year-old group was not vaccinated, and there's no difference in these times. So the lighter bar is the 2003 to 2006 before vaccination. The purple bar is 2009 to 2012 after vaccination was introduced. So the 25 to 29-year-olds who didn't get the vaccine, there's no difference. In the 20 to 24-year-olds who were vaccinated, there was a 34% decrease in the prevalence of those strains of HPV, and in the younger kids, there was a 64%. So you can see a greater reduction in the prevalence of HPV in the younger kids who were vaccinated, but even in the older kids, it was still effective. Here's some more Australian data. Again, the green line, over 30, they were not vaccinated because the vaccine is recommended at age 11 to 12. It's approved for 9 to 26. But I sort of feel like if you don't get it in before 20, you're kind of missing the window a little bit because you're just much less likely to acquire it after that. So the 21 to 30-year-olds have a decrease in genital warts, and the less than 21-year-olds have an even more drastic decrease. This is women and this is men showing the same thing. The people who are vaccinated have a much greater reduction in genital warts, which is an HPV-related condition. We also have good data that vaccination is safe. This is data from the Vaccine Adverse Effects Reporting System. And reports of problems from the HPV vaccine are primarily not serious. There were 7.6% of reports that were classified as serious. Most of those were headache, nausea, vomiting, and fever, which are things that can occur with any vaccine. There is definitely a report of fainting after this vaccination, which again can happen with any vaccine. If we think about originally when this was introduced, we were vaccinating teenage girls, which I think is the population that's most likely to faint after a vaccine. In my office, my nurses have a little phrase they put in the chart for every single vaccine, including flu shots, tetanus shots, saying the patient was asked to wait in the office for 10 to 15 minutes. And that is recommended by the CDC because after any vaccine, you could faint. Oh, I zoomed in on that, sorry. No, this is the part that makes me really excited, which is that we have really good data that younger people do better. If we give this at 11 to 13, it works way better. We can see a greater reduction in high-grade lesions. We can see an elimination of the people who got the vaccine at an older age, that's what this line I'm looking at, if they got it at an older age, it didn't affect their low-grade cervical lesions at all, but about a third, it was a big reduction in the people who got vaccine younger. If we give it after people have already had an abnormal PAP, we're not really doing as much good. So it's really good to get it in early before people are exposed to HPV and before they've had a chance to develop an abnormal PAP test. This is here just to show you that there's a lot of data here. We're not going to look at that, but what I want to just point out is what they did here. So this is using the GMT, which is the mean titer, the average amount of antibody that the people they were looking at made. And they compared girls who were 9 to 13 years old when they were vaccinated and women who were 16 to 26 years old. And they compared whether they got 2 doses or 3 doses in the younger group or 3 doses in the older group. And they looked at them at different different times after vaccination. So 7 months, 18, 24, and 36. And if you look at the whole chart, you can see that there's advantage even early on. But I really expanded this little corner down here, which was comparing at 3 years out. And so that's what this is here. So since it's a ratio, a number that's greater than 1, the numerator is larger than the denominator. So in a ratio that is greater than 1, the first listed group had a stronger immune response than the second listed group. And if it's less than 1, the second listed group had a stronger response. So here, where we're comparing the younger girls, 9 to 13 years old, who got 2 doses versus the girls who got 3 doses, you can see that 3 doses was more effective than 2 because the amount of antibody was larger in the girls who got 3 doses. If you compare the girls who got 3 doses to the women who got 3 doses, the girls made much stronger, twice as much of an antibody compared to the people who were vaccinated at 16 to 26. And in particular for HPV 18, which is that really nasty, aggressive one that causes cancer at a younger age that's harder to detect, there was a 3-fold greater immune response. And what I think is really fascinating is that that was even the case in the young women who only got 2 doses. The young girls, 9 to 13, who only got 2 doses of the vaccine still made a better immune response than the older women who got the full 3-dose series. So it's clearly more effective when it's given at this young age. The CDC is really trying to encourage us to give a good, strong, unified voice that HPV vaccination is an important thing and that it's important to do at 11 to 12 years old. We can definitely improve vaccination rates in the United States. I don't have the graphs in here comparing the US to other countries, but it's like I was saying, in Australia and the UK, they've achieved rates of 75 to 90% of getting people vaccinated against HPV. In the US, it's much less. And we can compare ourselves to ourselves by looking at other vaccines that we give at the 11 to 12-year-old visit. The blue bar here is tetanus shots. So we are really good at giving young adolescents tetanus shots. We're also really good at giving them the meningococcal vaccine. This is the same age at which we would recommend the HPV vaccine. This green bar is girls who got 1 dose of HPV. The purple is girls who completed the 3-dose series. Vaccination for boys was added in 2010, and that's really improved a lot. But you can see that for boys, we're still really lagging behind in terms of how many have been vaccinated with even 1 shot, let alone all 3. And this is really a missed opportunity because this is the same visit. If we were giving HPV vaccines at the same time that we gave tetanus and meningococcal, we would have way better distribution of the HPV vaccine among adolescents. And, I think this video starts out with some pretty funny stuff, which sort of explains, I think, why sort of the arguments people are making that are causing them to choose to not get the HPV vaccine when they're getting those other vaccines. So let's see what our time is. We might actually watch the whole thing, but we'll see. I'll see if I get bored with it.
Hi, I'm Dr. John Hallberg, an associate professor in the Department of Family Medicine and Community Health at the University of Minnesota Medical School. I'm also a practicing physician and the father of 2 teenagers. The purpose of this program is to learn how to deal effectively with 1 adolescent immunization. But before we show you how to do that the right way, we're going to start by showing you a few examples that are a little less than ideal. Let's take a look at the first scenario.
Kayla looks fantastic. Before you go, there are a few vaccines we give at the 2-month visit. Rotavirus, Hib, polio, the 2nd dose of hepatitis B, and the DTaP vaccine against diphtheria, tetanus, and pertussis. Also, there is one other vaccine you could consider.
What's that?
The pneumococcal vaccine. If you're interested, we could add it to the list, but it's up to you.
Of course this is silly. You know no provider would ever be so nonchalant about the pneumococcal vaccine. It's a safe, effective, life-saving immunization. But what if the patient is a preteen and the safe, effective, life-saving immunization we're talking about is the human papillomavirus, or HPV vaccine? Is it possible that we present that one as somehow less important? Let's check in on another scenario.
Adrian is growing well and meeting all her developmental milestones. That's great. Now, I'd like to open what might be an uncomfortable conversation.
About what?
Well, since Adrian's a year old now, she'll soon be interacting closely with children her own age. Diseases like measles, mumps, and chickenpox are transmitted by contact with sick people.
Okay.
If she hasn't already, she will start to reach out and touch other children, who in return will be touching her. I don't think there's anything you can do to really stop it. It's just natural. Keeping that in mind, I wanted to educate you about the vaccines that can prevent these diseases, and especially the diseases' relationships to social behaviors, so you can make a choice that's right for your child.
Well, most vaccine-preventable diseases are spread by contact with other people, but we just don't dwell on how people get infected. Yes, the HPV infections we're concerned about are transmitted through sexual activity, but we shouldn't treat the vaccine any different from the others we give. The whole point is to prevent disease, so adolescents need to be immunized before they become sexually active.
Well, I'm glad that Jack now knows that skunks don't like it when you try to cuddle them.
I do not think we need to remind him.
Just keep the wound clean, and if it starts to swell up, bring him back into the clinic, okay?
Okay.
All right. Oh, also, if you want, we could give him a rabies vaccine. It's your call. You're the parent.
Now, he's such a healthy kid. I think his body can fight it.
Frankly, I don't think he's the type to get it. He's not like those kids in other countries where they actually die from rabies. I wouldn't worry about it.
Okay. All right. Thank you.
No need for a rabies vaccine after exposure to a wild skunk? Of course that's ridiculous. And as you know, there's no type of person to get rabies, just as there's no type of person to get an HPV infection. Most Americans will be exposed to the HPV viruses that we're concerned about through sexual activity, and 22,000 of them every year will go on to develop a form of cancer that could have been prevented by the vaccine. It's well documented that a healthcare professional's recommendation is the single most important factor in a parent accepting the HPV vaccine for their child. We just need to be calm and upfront about letting them know how important it is to receive it.
I told you, this hockey is just not a good idea.
The rest of this is talking about giving it. I really like their little videos about comparing it to other things. Let's see if I can get out of this. It was tricky before. Okay, good. Oops. So the rest of the video is similar scenarios, but presenting questions that come up from parents and how we can address them. But I really like reframing the HPV vaccine and how silly it would be if we treated other vaccines the way we have sort of developed treating the HPV vaccine. And it's kind of funny that it's developed that way. The interesting thing is that the HPV vaccine is the only vaccine that will prevent cancer. We haven't clearly seen that yet just because we haven't had enough time, but I think it absolutely will. Once we are 30 years from now, we will be able to see that these cancers are less prevalent. So it just doesn't make much sense to me that we wouldn't give that prevention. The CDC has this handout, which it's not designed for, it's a portrait handout as opposed to a landscape, so it doesn't project very well. So I'm hoping that we can go through these things a little bit more. It doesn't, I'm not sure how well it presents. But it's really nice in that it goes through a few different questions that might come up and how we can present them to parents. So as we heard in that video, a recommendation from providers is really strong. And I'm finding this now that we have the flu shot in our office. Maybe a third of my patients or half are very excited to get their flu shot and they would have gotten it 2 months ago. There's some who totally don't want it. And then there's a few who say, well, you really get it. I've never gotten it. And I found that if I say to them, well, the reason that we want you to get the flu shot is not necessarily to protect you, but to protect everyone else too, because if you have immunity, you're less likely to have an infection with no symptoms and less likely to pass it on. So from a public health perspective, it's to our advantage to have as many people vaccinated as possible. And just in this week where our flu shot was available, maybe half the people I've had that argument with have said, okay, fine, Dr. Keegan, I'll get my flu shot. But they wouldn't have gotten it if I hadn't gone through that with them. So I really do think it's worth doing. So I think emphasizing that the HPV vaccine causes cancer is really useful. I'm going to just back up 1 second and say the first thing I do is I often don't have to have any of these arguments because I approach it now as it's our 11-year visit. This is a tough one because there's 3 vaccines. We're going to do the HPV vaccine, which protects against HPV-related cancer. We're going to do the Meningococcal vaccine, which protects against meningitis, and the Tdap vaccine, which protects against tetanus, diphtheria, and whooping cough. And I just lump it all together, and they say, okay, and the kids get their 3 vaccines, and we don't have any argument. But sometimes you will hear, well, gosh, I don't know about that HPV vaccine. Isn't it new? Or is it really safe? Or my kid's not going to have sex until she's married, so she doesn't really need that vaccine. And so then it's kind of nice to be armed with some of this data. So that's why I presented the data up front, so we all understand why some of those arguments don't totally make as much rational sense, and then we have a way to address it. I do a lot of motivational interviewing work, and so I really do try to take that approach. And that approach is really meant to be a patient-centered approach, which is not us being an expert over here who knows everything and tells them what to do. Instead, we want to really explore what concerns people have. So I start by saying, if I'm getting the sense that they're not interested in this vaccine, I start by asking, what are your concerns about the HPV vaccine specifically, so that I know what it is I need to address, rather than launching into a 30-minute lecture that might really bore them or lose them. And then once they tell me, I ask permission to give advice. Would it be okay if I explain to you what we know about that or what our perspective is on that? And then generally they say yes. If they said no, I would say, all right, just know that I'll bring it up again next time you're in, and then we move on. But generally they say fine, and then I explain it. And again, sometimes they'll still say no, thank you, and then I say, that's fine, we'll bring it up again next year. So I do emphasize against some of these concerns. One is that HPV is a vaccine that can prevent cancer, which is a scary thing for people. People don't want their kid to ever have cancer. I don't show them pictures of squamous cell carcinoma of the penis in the office, but if they, I feel like that picture enough should get anyone to vaccinate their sons. sometimes they're not really clear about what it protects against, and so then I emphasize that it can protect against abnormal pap tests, so women need to come back for fewer gynecologic exams if they don't have HPV, and then that it also causes cancer of the throat, cancer of the penis, cancer of the anogenital tract. I try to avoid using the medical terms, but sometimes I throw them in there a little bit. Let's see. This next one is about the best protection. So I feel really confident now that I can say, I understand your concerns. It's actually really more effective if we give it now at 11 years old. If you'd like to think about it, 12 years old is still a really good time. But if we wait until your child is 16 or 18 and can officially as an adult make her own decision, she'll actually get way less protection than if we get it now. I've never heard this one myself, that parents are concerned that if we vaccinate their kids against HPV, it'll be permission to have sex. I haven't heard that in my own, you've heard that one? Yeah. They've studied it, and the kids are having sex whether they get the HPV vaccine or not. So it doesn't actually seem to cause them to have sex more. Yes, in their family, they right, we have taught them that you're not going to have sex during high school. So that's fine. So then I might emphasize that we actually have good data that HPV can be acquired without any sexual intercourse at all.
Is there any, I'm sorry.
No problem.
Is there any information on how that occurs?
The question is there any information about how that transmission has occurred? And part of it is, as I said, the vertical transmission from mother to baby. So then the mother might say, well, I clearly don't have HPV. But there's also, I think it can be transmitted from child to child, just like measles and chickenpox. So I think that there's some transmission just by being in contact with other people. And if we mention that HPV is, the HPV that causes cervical cancer is in the same family as HPV that causes plantar warts, I think people can understand that it's really easily transmitted, and you can't necessarily protect yourself. Even if you wear flip-flops in the gym shower, you might still get a plantar wart. It's really hard to avoid. Does that answer your question?
What about cold sores?
Oh, cold sores. Cold sores are caused by herpes simplex virus, which is a different family of virus, but there's actually a lot of overlap. And I've actually learned a lot from how I talk to my patients about HPV, and I project that onto how I talk to my patients about herpes, because people get really upset that they have herpes. Herpes is incredibly easily transmitted as well. So I try to emphasize to people that, kids get cold sores. They didn't get cold sores by having sex. They got cold sores by kissing somebody who was infected with herpes who didn't have an active cold sore. You don't necessarily have an active cold sore every single time when you're able to pass on the herpes virus. So herpes is a little bit more loaded, but there is a lot of parallel. It's a skin-to-skin transmission, and that skin-to-skin transmission can be insertive intercourse, but it can also be touching an infected area with your finger and then transmitting it somewhere else. And that's why with herpes, traditionally, they would say that herpes type 1 causes cold sores and herpes type 2 causes genital lesions. But it's all mixed up now because people's mouths touch other people's genitals. So you can have herpes 1 of the genitals, which actually tends to cause a milder genital disease course. And you can have herpes 2 causing cold sores. Herpes 2 is definitely more aggressive, but it's all mixed up. So it's not as simple as that. Cold sores are different, but it's a nice analogy, I think, in that you can certainly get cold sores without ever having sex, and it's the same with HPV. Yes?
I'm just sort of thinking through this conversation, as if a parent saying, well, so they wouldn't necessarily have to have sex, but would somebody have to touch my child's genitals to give them the HPV virus?
Well, the question is, what about, is it just genital touching? And that would cause HPV. And I think you would have to have genital touching in order to get cervical cancer, but you don't have to have genital touching to get oropharyngeal cancer. I think that could be transmitted through kissing. I suppose that there are socially conservative families where they suggest that people shouldn't kiss either, but I think it's not necessarily realistic. I try to not get into a really detailed conversation about who's going to do what with whom when I'm in an 11-year-old visit with the parent present. So I try to avoid that. I really try to redirect it toward the not sexual related effects. And then there's a whole second set. So some of these we already addressed. Their child won't be exposed because they aren't sexually active. And I do emphasize it's as common as the common cold. 95% of people have had HPV at some point in their life. Helps, let's see. Oh, my personal belief should help them feel like I vaccinated my husband took my son to his 11-year-old well-check this summer, and he sent me a text afterward saying he got the meningococcal and the Tdap vaccines, and his doctor said he could wait on the HPV vaccine. And I said, whoa! Well, good thing we're going back in a month for a weight check because he's getting his HPV vaccine now while he's 11. So I can honestly say I have vaccinated my child. It's very important to me. I think that it's something that I would do for my child. That is the strength of my recommendation for this. Sometimes people are concerned about side effects, and I talk about that part where fainting, the side effects we've seen with the HPV vaccine are very similar to other vaccines. It's not the HPV itself, it's just the fact of getting a vaccine. It looks like the CDC has found that parents want to know it works, and I think we can say very strongly that it does work. We haven't seen the effect on cancer, I keep emphasizing, because we just haven't had the time yet. And it's really important to remember that it takes 3 shots. So when I do that 11-year-old visit, I put in my little checkout information, please schedule a nurse visit at 2 months and at 6 months. So they've already got it on the calendar. And I enter in that vaccination order for the HPV vaccine as a standing order so that they don't have to come find me to get me to order it again. That's the whole story. So these are the things we went through, what HPV is, what the characteristics of HPV are that cause it to do what it does, what we know about HPV and cervical cancer relates to other cancers. The vaccine that we have available is effective and it works, and I think it's going to reduce cancer prevalence in the future. We just need to get kids vaccinated so that we can see that effect. Other questions? There's some references. Ms. Courier. Right, so this is about children who are older adolescents and then into the 20s. Is there benefit in vaccinating if they've already missed that window? There absolutely is. Even if they've been exposed to HPV, we don't know which strains they were exposed to, and especially now with the nonavalent vaccine, there's a very good chance that they haven't been exposed to all 9 strains that are covered by that vaccine, so there's definitely still benefit. I have to say, when I see a 25-year-old person who hasn't been vaccinated, who's in a stable monogamous relationship, maybe I should give a stronger recommendation at that point, but I kind of feel like the ship has sailed in the 25-year-olds. So it's approved up to 26, but I really push it maybe to 24. Yes, please.
I had a patient who had an atypical pap. This was in the years when we did paps at sexual activity.
Yes.
Onset, and she had an atypical pap, and is it still advised to give HPV in someone who's 17 or 18, or even a little older than that, who
Right.
has an atypical pap?
So the question is about giving the vaccine in someone who's already had an abnormal pap test. And again, like you pointed out, in most 17 or 18-year-olds, we won't have this come up. But let's say your patient happens to have gotten a pap test somewhere and you see that they had an atypical pap with HPV present. Again, I would say it's still worth giving because when they say whether it's high-risk HPV positive, they're not saying which strain they had. We know that they detected a high-risk strain, but we don't know which one. And it's quite possible that it's possible they've been exposed to all 9 strains, but it's more likely that they haven't been. So they can still get additional protection from those other strains. What was I going to say? The other thing that can come up is that, oh my gosh, it just popped out of my brain again. Right. So some people have asked, will this HPV vaccine affect my child's fertility? And the answer is no. In fact, it's more likely that HPV infection would affect your child's fertility. Because if someone has an HPV infection that's so severe that they need excision of part of the cervix, that can lead to scarring of the cervix, which can contribute to preterm labor risk and preterm birth risk. So that's another thing that we can prevent. Was that my time, Mark? We're out of time, or that was the 5 minutes? Oh, 2 minutes. Great. Yes, please. Next question. Yes, I recommend the nonavalent. That's what we have available in our office now. If someone has completed the series with the quadrivalent vaccine, they do not need to repeat the series. There isn't really benefit because you've already been protected against about 66%. So they've gotten good effect. If they've received 1 or 2 doses of the quadrivalent, I complete the series with the nonavalent. But the recommendation right now is if for whatever reason what you have in your office is the quadrivalent, the Gardasil, that's fine. Use the quadrivalent. The quadrivalent's going to give really good benefit. The nonavalent just adds in a little extra bonus. Yes? This question was about throat cancer. Are most of them related to HPV? There's sort of 2 chunks. There's a chunk that's not and a chunk that is. And the chunk that is actually increasing in prevalence. So we're seeing more and more cancers of the head and neck that are in younger people and they're more aggressive, and those are HPV related. The ones that are not HPV related, which are sort of the smoking, drinking, middle-aged man cancer, those are sort of staying the same. And then we're seeing a bigger and bigger chunk of people with HPV related cancer. What is the brand of the nonavalent? I think it's called HPV 9. Brilliantly enough.
You said that was the most recent?
The HPV 9 is the most recent. That was released, I think, within the last year.
Has there been any study correlating the effect of HPV vaccine in women who are BRCA positive?
The question is about HPV vaccine in women who are BRCA positive. Not that I know of. The BRCA cancers are less related to HPV. They're a different route. Why are HPV cancers on the rise? I don't think people are having more sex than they used to necessarily. I think people have always had a lot of sex. I think that there's sort of ups and downs. Like there's been times where syphilis was way more prevalent, and then syphilis was less prevalent, and now syphilis is actually becoming more prevalent again. So I think that there are just sort of ups and downs, sort of like different years the flu is worse and other years it's less bad. So I think HPV is currently on the rise. We'll see. Is it because there's more oral sex now? My instinct would be that there's been oral sex all the time. I don't know. Maybe there's more oral sex. Because teenagers sometimes say you can't get pregnant if you have oral sex. I actually knew someone when I was a teenager in the early 90s who was having anal sex because she couldn't get pregnant. And I would guess that that sort of thing also, I mean, I don't know whether that's something that's becoming more popular in adolescence. It could be. I think that teenagers now, we're not seeing that affecting cancer yet.
A little off topic, way back in the 80s, we used to spend a lot of time trying genital warts. What is the recommendation now?
What is the recommendation for genital warts? If they are isolated, you can use any destructive method that works for you. You can use cryotherapy. You can use trichloroacetic acid. I like the TCA because I feel like I can put some Surgilube around the wart and be really local, but it requires that I have TCA that isn't expired in my office, and I don't use it as much. So either of those. You can also use prescribed Podophylox, or there's a couple different prescribed things that. Yeah, because they can go away on their own, but people, once you've diagnosed them with genital warts, people are really bothered by that, and they worry about passing them on to their partner. And I think that if you don't destroy them, they're going to keep shedding virus. So there are options where you can do a prescription and the patient can apply it on their own at home, but they're not generally covered, but they're really expensive. If they're very extensive, then I refer them to either Dr. Moore here, who's a colorectal surgeon, to do a more invasive, or to Dr. Everett in gynecologic oncology, because they are surgeons who can do a much more extensive excision if they're really bad. Thank you. Thanks for coming.